Welcome to the Clinical Research Podcast, bringing you the latest developments in research explained by our world-leading clinicians, academics and scientists based in Nottingham. This episode looks at research into advanced glaucoma treatment and a study called TAGS, which stands for the Treatment of Advanced Glaucoma Study. It's led by Professor Anthony King at Nottingham University Hospital's NHS Trust, and it's investigating whether it's better to treat glaucoma with eye drops or with surgery. Professor King told me about the problems of treating the disease.
One of the problems with advanced glaucoma is that because glaucoma is a very slowly progressive and insidious disease, often people are unaware of it. It creeps up on them and it's only detected quite late in its course when their vision becomes affected. And if your vision has become affected from your glaucoma, you've already got very advanced disease. It also tends to affect some ethnic minorities, such as those from Afro-Caribbean backgrounds and those from a poorer socioeconomic background. This will help hopefully target those groups more effectively.
Are there any early ways of spotting if you've got glaucoma? I'm just thinking for the benefit of people who might be thinking, I wonder if I've got it.
So sadly, there aren't really any early ways of reliably detecting glaucoma. Most glaucoma is detected by opportunistic case finding when a patient goes to their optician finds that their pressure's high or that they may have a visual field defect on visual field testing, and then they refer them for assessment for their glaucoma. There is an increased risk of developing glaucoma if you have a family member, a first-degree family member, that increases your risk.
Moving on to your study, what was that designed to find out? What was the research question, I guess?
So the research question was really to determine whether or not using two well-established methods of treating glaucoma, that is drops or primary surgery with trabeculectomy, which are both established treatments within the NHS, whether one of them is better than the other in protecting people with advanced glaucoma from progressing, and also exploring how it affected their quality of life.
Can you just explain what a trabeculectomy is?
Glaucoma is a condition which is related to high pressure in the eye, and the only known way of treating glaucoma effectively at the moment is to reduce that pressure. So all of our treatments are aimed at reducing pressure in the eye, whether they be drops, laser or surgery. So a trabeculectomy is an operation which we undertake on the eye for patients with glaucoma, and essentially involves making a small hole in the eye which allows the fluid to drain out of the eye at a very slow pace, but that flow of fluid from the eye reduces the pressure in the eye.
Okay, so that's one way. Basically, you cut a small hole and let the liquid dribble out. What
the fluid drain out? Yeah, it's a bit more sophisticated than that, but that's essentially the plumbing involved. Yeah.
Okay, and so what do the drops do?
So the drops, and there is about 5 or 6 different types. They also reduce the pressure, but essentially the patient has to put the drops in their eyes at least once a day, sometimes maybe 5 or 6 times a day, depending on how many drops they're using, which is inconvenient and which also can be a bit uncomfortable for patients because they sometimes are irritating to the eye and have other side effects. And we know also that because of those things, and also because we're particularly dealing with an elderly population, because it's primarily in the elderly that glaucoma occurs, sometimes putting drops in can be a bit technically difficult, and sometimes there are some memory issues which affect patients' ability to put the drops in frequently. And obviously, if you're not putting the drops in, you're not getting any value from it.
I'm guessing that for that same group, there's also going to be issues over surgery as well.
I don't think there are any issues in the elderly age group with having surgery or with the outcomes of surgery. In fact, the outcomes of surgery are generally better in an older population than they are in a younger population, because surgery fails most frequently because it scars down afterwards. The hole that we create scars over. And this seems to occur more aggressively in young people rather than in older people. So, and also people's willingness to have surgery is pretty high. We found that most people who participated in tags and were randomized to surgery were willing to go ahead and have it. Actually, patients are most really concerned about their quality of life outcomes, and they're willing to undertake whatever treatment is necessary for them to achieve those.
How did you design the study then to answer that question?
We designed it as a randomized controlled trial. So essentially, we obviously did a power calculation. We identified that we needed 440 patients who were allocated either to medicine or to primary surgery. So about 220 in each study arm. And then we followed them up for 2 years. The only study intervention was whether they had drops or surgery. After that, it was standard care. So essentially, the clinician looking after those patients then decided what further interventions they needed, if any. And at 2 years, we evaluated their quality of life and their clinical outcomes, and also the cost effectiveness of those interventions. There were 27 different centres in the UK involved in this study. So, and about 60 or 70 surgeons, because we really wanted this to be representative of what happens in the UK. We wanted it to be identified as a very pragmatic trial, which reflects what actually is going on in the NHS and the true outcomes that we achieve.
And what was it that you found? What were the results?
So what we found at 2 years is that in terms of quality of life, there's no material difference between drops and surgery if you have them. So patients are equally happy with either. When we look at the clinical outcomes, we found that the pressure, which I mentioned earlier as the main treatment aspect of glaucoma, was markedly lower in the patients who had trabeculectomy by about 3 millimeters of mercury, which is clinically significant. That's obviously the patients who required trabeculectomy had trabeculectomy, we were using far fewer drops than those who were automatically in the drop arm. In terms of vision, we found no clinically material difference between either the visual acuity, which is the ability to see letters on the chart, or the visual field change, which is the test that you do looking at the flickering lights when you go to the optician. So in terms of cost effectiveness, we found that it was cheaper to undertake drops over 2 years, but modeled over a patient's lifetime, the suggestion was that probably trabeculectomy was cheaper. But of course, we've only got 2-year results to make those assumptions on.
So are you continuing to monitor and follow up?
The HTA have awarded us some additional funding to review these patients again at 5 years. And this is very important. Patients with glaucoma have lifelong follow-up. Their disease stays with them for the rest of their lives. So what we really want to know is what the lifetime outcomes for patients are. And 5-year outcomes will give us a much better insight in that. And it's normal for patients with glaucoma to continue to be followed up every 6 to 9 months routinely anyway. So we will be able to collect this data to inform these outcomes.
And so what are the implications, do you think, for treatment clinically in the future?
I expect the results of this study will be incorporated into the various glaucoma guidelines in the UK, in Europe, and around the world. So the outcomes suggest that because surgery reduces pressure more, it may actually have better long-term effectiveness, even though that's impossible to predict with certainty with 2-year outcomes. One of the big concerns that surgeons had with undertaking a primary trabeculectomy, that is your first choice of intervention, was that all operations are associated with complications. And they wanted to be they were uncertain what the safety aspect was in terms of glaucoma surgery in this group of patients. And essentially, we found that there was no serious sight loss associated with glaucoma surgery. And at 2 years, essentially, both sets of patients had the same quality of life. So I think that has allayed, to some extent, the concerns about the risk of complications with surgical intervention.
Do you think there's likely to be any cost implications?
So there is an upfront cost for surgery. Upfront surgical costs are more expensive than than the drops. But I suppose that the point of the cost evaluation is to look at it over the lifetime of the patient. And the modeling suggests that trabeculectomy in the long run will be more cost effective than the drops. But of course, it's modeled, and at 2 years, the trabeculectomies are still more expensive than drops.
I think that covers everything I wanted to cover. Is there anything else you wanted to particularly say?
No, I just wanted to say a big thank you to all of my colleagues throughout the country who have participated to recruit patients and follow these patients up to make TAGS a very successful study. Without them, we wouldn't really have been able to achieve this, and thanks to all the patients also for agreeing to participate, because without them, we wouldn't have been able to achieve this either. And also to thank them all for the continuing and ongoing support, because they are still following these patients up for the 5-year study, which is extremely important.
Brilliant.
Lovely. Thank you very much, Matt.
Cheers. Thank you. Bye-bye. Thanks for listening. There are links in the show notes for more information on clinical research in Nottingham, and the website is nuh.nhs.uk/research. Our email and social media links are there too. If you want to stay up to date with the Clinical Research Podcast, you can find us on iTunes, Spotify, Google, wherever you normally get your podcasts. The more shows are rated and reviewed, the more search engines like them, and the easier it is for people to find us. So if you can subscribe and rate and review us, you'll be doing it for science, not just for our egos.